Education session on EKG placement for acute coronary syndrome patients. Before we get into this education, I just want to make sure everybody's aware. We're just going to go over placement of the leads and best practice. We're not actually going to go into reviewing 12-lead EKGs and 15s and diagnosing them. So this statement here just came out of the 2025 American Heart Association guideline from ILCOR standards. So this basically saying that it's very important we get effective 12-lead ECGs as paramedics pre-hospitally. It's really important that we recognize the need for it. We are able to diagnose it very quickly to introduce reperfusion therapy as soon as possible for better life, better quality of life and survival rates for our ACS patients. So when it comes to 12-lead acquisitions, so again, coming from the 2025 guidelines, this is straight from ILCOR, the people that oversee like American Heart Association and Heart and Stroke in Canada. It's a #1 recommendation that if we have a patient with suspected ACS, we get an ECG completed within 10 minutes of patient contact. Trying to match these guidelines in our care map, it also says the same thing. So if we have a suspected ACS patient, ideally we want to get them on the monitor and complete a 12-lead within 10 minutes of arrival. Again, the sooner we get these done, the sooner we can diagnose, the sooner we can get them to reperfusion therapy, which is the ultimate goal and better for our patients' quality of life. So before we put ECGs on people, we want to make sure that we check our electrodes. So we want to make sure that electroconducting gel is not wrecked on these leads. So if they expire, the gel is not as effective as conducting. Also, if you're in the practice of taking the electrodes out of the packages at the start of your tour and applying them onto your leads, and just letting them sit there for a couple of days, it's not recommended by Zoll. Like, they put them in foil packages for a reason. So they said they want to keep that gel moist because it's going to improve the chances of catching something, because it's going to be better at picking up the electricity going on through the heart. If your electrodes are dried out, the electrolytes within that gel aren't going to pick up the electricity, and it's not going to get a good reading. So make sure you're using not like that electrode that's been sitting on the shelf for the last 3 weeks, because you need that extra one electrode or extra sticker. Make sure you're using new ones outside of the pack. So we want to make sure they're applying our electrodes to just clean, dry skin. So we might have to just towel them off, because patients with ACS may be very diaphoretic and the electrodes are not going to stick to that. So you want to make sure you're drying off the chest. You want to make sure you're shaving the chest, because if we have a patient like this where you've got electrodes actually on the chest hair, this is going to affect how we get a reading, because it's not going to get the best tracing because we're not actually attached to the skin. Plus there could be artifact because they're not actually connected to that skin. They're just kind of moving on the chest hairs, so that can cause artifact and poor quality readings. And it can cause lead faults as well. If you've ever had lead faults on your ECGs, it could be that the electrodes, like the Zoll's trying to read them, but there's just poor contact. So the Zoll's trying and trying, and it just gives up because it just can't get a good tracing because the electrodes aren't applied appropriately. So we want to make sure we're getting the best reading we can. So that means drying off the skin, putting them right on there. And Zoll also recommends that if there's a lot of dry skin, just take like an abdominal pad or a piece of gauze and debride the areas where you're putting your leads. And then that way it'll get better skin contact. We're pretty good at doing this for 12 leads, but when it comes to doing your 3 leads, we should be doing this practice as well. So that way we get good contact with the skin and a better tracing for our diagnosis. So applying them over bone. So when it comes to putting ECG leads on, we shouldn't be applying them on the ribs. That's why with our 12 leads, we want to put them on intercostal spaces. Because what I have here is a picture of a low amplitude ECG. So with that, as a patient may be obese and a lot of adipose tissue, or if there's fluid around the heart, things like that can dampen the electrical effects, so the EKG is not going to pick it up. Putting your electrodes over top of rib, that's going to block that electrode's ability to get a proper reading, so you may get very small tracing. So if you're finding you're getting this a lot, make sure you're landmarking appropriately, and we're not putting them on the actual ribs, we're putting them in their intercostal spaces. So this is where landmarking is really important in these readings. We want to avoid areas with lots of muscle activities. So, if there's someone that talks with their hands and they can't stop talking during a 12 lead, maybe limb leads is not the best place to put it. Maybe we want to put them on the chest, because again, we're going to get a lot of artifact. And a big thing as well is we don't do 12 leads while we're actively driving. So if you did one in the house and everything looks fine, during transport, you should be doing repeat EKGs. So if you're going to do a repeat one on route to the hospital, we should be pulling over and stopping to get a proper tracing, because as we're moving, there's vibration, there's patient movement, or it's going to affect how our ECG comes out. So we want to make sure we stop the ambulance to get a proper reading. So limb lead placement. So this picture here, this is straight out of the Zoll's X-Series Operator's Guide with recommendations on where to put the limb leads while you're doing your 12 lead. So your right arm or your white electrode, they want you to place it near the patient's right midclavicular line, directly below the clavicle. Your left arm electrode, so this is the black one, you want to place it near the patient's left midclavicular line, directly below the clavicle. Your lower leg on the left side, the red one, we're going to place between 6th and 7th intercostal space, left midclavicular line. Again, it's got to be on the intercostal spaces, not on the ribs. So your right leg, lower leg, your green electrode, we're going to place between the 6th and 7th intercostal space on the patient's right midclavicular line. So again, this is a recommendation from Zoll because again, you're closer to the core, you'll get a better reading, reduces artifact. But limb leads can be put on the limbs. There's absolutely nothing wrong with that. That's in their name. So with that, again, we just look at our placement here. So it's white on the right. That smoke over fire thing still applies. Just keep in mind that if you are doing a 12 lead, you have to really get your patient to stay still. Because again, if they're talking with their hands a lot, they won't sit still, they're very agitated, things like that. We're going to get a lot of artifact if the leads are on the actual limbs themselves. So we just have to make a good decision of what's going to get the best tracing for our patient. There has been some recent studies coming out lately that show you do get a better reading on a 12 lead if you put the limb leads on the limbs, which I'm totally not against. We just have to make sure that we're not getting artifact with it as well, because we might get a better tracing if they're sitting still, but if they're moving a lot, that's not going to work for us. So you might look at putting them on the torso instead. So you got a couple options there. So we look at our actual leads here. So this is lead 1. So when we're doing our 3 lead, initially we're going to probably put this on first. You can't do a 12 lead without 3 leads, so we're going to put our 3 leads on. So this is lead 1 here. So the negative electrode is on the patient's right shoulder. So if it's moving away from there, you should get a positive tracing. So this is lead 1. So you can see it's going from right shoulder to left shoulder. So it's going away from the negative electrode. So you should get upright morphologies for all your different waveforms. We look at lead 2. We use this one most commonly for when we put our patients on first, because this shows the flow of energy running from the right shoulder to left foot, which is also the way the sinus, your normal electricity goes from your SA node, your AV node, down your bundle of His, all that good stuff. So these ones should all be positive as well and upright, because you're going away from that negative electrode. This EKG, we've got lead 3. So with that, we are still should be getting positive upright inflections on all our waveforms, because we are going from that negative electrode on the left shoulder down to the left foot. So it should be positive when we look at these leads. And again, this is important to know, because if we see any changes in this, whether things are inverted, that can really give us an idea that something's not right with this ECG, and we should do more investigation to our patient. We also have our augmented unipolar leads. So this is your AVR, AVL, and AVF. So AVR is your augmented vector right. It should always be negative because it's going towards that right shoulder, which is your negative lead. So it can be inverted. There has been recent studies that have come out saying that if you have a lot of positive deflections in AVR, it could be an indication of a STEMI. We're not using that as an absolute diagnostic tool for what we're doing. So we should, if we see something abnormal in AVR where a lot of our waveforms are positive, that should definitely be taken as an indicator to do a 12 lead on our patient. But as of right now, we're going to be looking for those negative deflections. That should be normal. It also helps you make sure that your electrode's in the right place, because check your electrodes first. If you accidentally put things backwards, it may be a positive inflection as well. When we have AVL, so that's augmented vector left. So with that, we're going down. Going up towards that left shoulder. So again, everything should be more of a positive deflection. And same thing with AVF for augmented vector foot. So those should all have positive deflections as well, because they're all moving away from the negative electrodes. So when we put all these together, so we got our lead 1, 2, 3, and our AVR, AVL, AVF. So these are all what we call like Einthoven's triangles. So this is the big thing. We're looking at all the different views of the heart. The big thing to take home from this is that it's good to know what they look like normally, so we can see if there's aberrancies, and we can do our 12 lead based on what we're seeing when things don't look normal. The other thing as well is that these aren't diagnostic. So if we do see something, like if we do see ST elevation on, say, lead 2, that's non-diagnostic. It's just giving us a really good indicator that we need to do a 12 and or 15 lead, because the 12 lead is a lot more sensitive. It's a lot more effective at picking up electrical waveforms. So we should be doing a 12 lead to confirm. Again, we can't call in with a lead 2 ST elevation saying we've got a STEMI. We need to do a 12 lead to confirm that suspicion. which leads us to our precordial lead. So we're getting into the actual 12 lead itself. So when we landmark for these here, so as you can see, we've got all our different stickers here. So we have V1. So this goes to the fourth intercostal space right of the sternum. We have V2, which goes to the fourth intercostal space left of the sternum. Again, intercostal spaces, not on the ribs. So we do V1, V2, then we're going to do V4. So with that, we're going to go with the fifth intercostal space. We're going to use that mid-clavicular line, so make sure you're going mid-clavicle. A lot of times people tend to go too close to the sternum for this, so make sure you're actually finding that midline in the clavicle. Don't just eyeball it. Make sure you're actually looking for that spot and follow it down and put it on that intercostal space there. So we do V4, so we did V1, V2, V4, and then we're going to do V3. So I just told you not to put it on the rib, but V3 is going to end up on a rib because if we got one electrode on V4, one on we got V2 on the fourth intercostal space and V4 on the fifth intercostal space, V3 is going to go in between. So unfortunately that one does have to go on a rib there. So we're just going to place it as close as we can, as you can see in that line, between V2 and V4. Then we're going to do V5. So this one is the fifth intercostal space. We're pretty much going to follow the fifth intercostal space as we go around. And we're going to use that anterior axillary line. So when we think about that, it's basically if you take the armpit, you go straight down, that's going to be your fifth intercostal to the fifth intercostal space. And that's where we put our electrode. And then we could do V6, which goes to the fifth intercostal space, mid-axillary line. I know it's the practice of a lot of people out there to do V1, V2, V4, V3, V6, then V5. So the landmark V6 with that mid-axillary line on the fifth intercostal space and put V5 midline between V4 and V6, and that's completely fine too. It's whatever works best for your practice. Perspective, we're going to put our leads for doing our 12 leads. So V1 to the right of the sternum, V2 to the left of the sternum, V4 at the mid-clavicular line. Again, make sure you're not going too close towards the sternum. We want to make sure we're getting a good picture of the entire ventricle there. And V3 just in between V2 and V4. And then V5 there, so that's that anterior axillary line, so the front end side of the armpit. So V6 is going to be actually going down the side on the mid-axillary line, but V5, we just want to find that anterior aspect of the armpit and go forward to that fifth intercostal space. So it should wrap around the chest a bit more. You shouldn't have all your 6 leads on the front of the chest. Look at our 12 leads. What are our electrodes looking at and why is placement so important? So when we look at V1, V2, these are your septal leads. So these ones tend to look more at the septal wall, so the left and right side of the septum in the heart. So these ones tend to get a bit of a right-sided view. So V1 AVR, these ones look a little bit at the right side of the heart. But when we look at this chart here, most of our leads are looking at the left ventricle. So when we look at V3, V4, with these ones, this examines the left side of the ventricle. So these are your anterior leads. We look at V5 and V6, but this also includes lead 1 and AVL. These ones look at the lower left side of the heart. So these are your lateral leads. Other ones we have here as well as your inferior leads. So these actually look at the underside of your ventricle. So again, there's a little bit of a view of the right ventricle there, but for the most part, these leads are looking at the left ventricle. This is why it's important when we go into 15 leads later, that our 12 leads really set up to look more at the left side of the heart. So if we are suspecting a right-sided MI, we need to make sure we're moving our electrodes around. Okay. So just for this here, we look at our precordial leads. So in the video, we take V1. Again, we go down the right side of the sternum to that fourth intercostal space. We've made sure our electrodes are all good and clean and ready to go. We've shaved the chest. We've wiped off the sweat, things like that. The next thing we're going to do is do that left side of the sternum, fourth intercostal space. Then again, we're not going to do V3 right away. We're going to take V4. And again, we're going to find that midpoint in the clavicle, and we're going to go down and we're going to get to that fifth intercostal space. Now we might have to move up adipose tissue or breast tissue out of the way. We want to try and get on that intercostal space as best we can. And then we're going to put on our V3. So if we are trying to put on V4 and there's just too much tissue in the way, or we just physically can't get to lead to the fifth intercostal space, just try and get as close as you can. If it's a little bit below, that's fine. We want to try and get as close to that spot as you can if there's anatomical issues in there. So now we got 1, 2, 3, 4 on. So again, now we're going to go to that anterior axillary line. We're going to get, again, that anterior axillary line, find that fifth intercostal space, and we're going to put on our V5. And then we're going to find that mid-axillary line, take off our electrodes, and we're going to find that fifth intercostal space. and we're going to apply V6. And again, it's completely fine if you want to do your V6 first and then put your V5 in between. So again, we have to kind of remember that we want to follow that curving of the ribs, so we stay in the intercostal spaces. We want to do a 15 lead. So patients with right-sided MIs may exhibit the exact same symptoms as someone having a left-sided infarct. So your chest pain, dizziness, nausea, signs, symptoms of shock, fatigue, all that good stuff there. So they're going to present very similar. So the big thing with right-sided is that if we're seeing conduction disturbances, this can lean more towards a possible right-sided MI. So the patient's presenting with new onset of things like bradycardia, heart blocks, hypotension. That is a very frequent symptom in right-sided MIs, so we want to make sure that we're investigating the full heart. So even if your 12 lead is saying STEMI, we should still do a 15 lead to check the right side of the heart as well, because again, it can affect the whole heart. So we want to make sure we're checking the whole 100% of the heart, just not about 75 to 80% of the heart. Other things you might see with your patients with right-sided MIs, like especially if they have a history of heart failure, be worsening peripheral edema, JVD may also be present. So we want to look at all these signs and symptoms, and if those are present, we should be doing a 15 lead as well. Because your 12 lead, a conventional left-sided ECG, has very limited sensitivity for detecting the right ventricle because the right ventricle lies a little bit more anterior. And as we saw in our chart earlier, most of the leads are looking at the left side of the heart. So we need to make sure we're checking the whole heart. So when none of those symptoms come up, or if you have a patient that you do a 12 lead that present completely like an ACS patient, but their 12 lead says, nope, they're good, no MI found, just says normal sinus rhythm, we want to make sure that we check the right ventricle to make sure that that's not involved as well. So again, if you're highly suspect your patient with ACS, but their 12 lead says they're fine, make sure you follow up with a 15 lead to confirm with the whole heart. So when we look at this 12 lead that's on our slide here, you can see that this is just completely normal sinus rhythm, but the patient in this picture here, they were complaining of complete ACS symptoms. So the paramedics did a 15 lead, and upon that in lead 789, they found there was ST elevation in multiple leads, confirming a right-sided MI. So that's a big reason why we want to do 15 leads, is just investigate more. We have the ability to check the whole heart, so we want to make sure we're not ruling out right-sided MIs. Other things that might make us think we need to do a 15 lead. So for those of you who are good at reading 12 leads, we want to look at if there's ST elevation in lead 3. If that is greater than what's in lead 2, it's highly suggestive of right ventricular infarct and should prompt a right-sided ECG. ST elevation in lead V1 is also an indicator of right-sided MI, because as we said before, V1 looks at that little bit of right side of the ventricle. So with that, we want to make sure we do a 15 lead, sorry, so a right-sided 12 lead, particularly when it's accompanied by ST depression lead V2. ST elevation in lead V1 greater than V2 also supports that there's a right-sided MI. So those are some things we can look for when we're trying to decide if we want to do a 15 lead. So this one here, we have an inferior lateral STEMI. So with that, we're seeing horizontal ST depression in V1 through V3. So like I was saying, this could be reciprocal changes of something that's happening on the right side of the heart. So if you're seeing something like this, we should be doing a 15 lead. And as you can see here on their 15 lead, when they performed it, you can see that ST elevation in V4 through V6 on the right side, so V7, V8, V9. So we want to make sure that if we're seeing those reciprocal changes, but not ST elevation really anywhere, we should be doing a right-sided 12 lead. So to do a full 15 lead here, so we're going to move some leads around. So the big one is we're going to take V4 from the left and move it to V4 on the right. This is a big one. V4 is kind of our go-to for right-sided. The big thing is if you're going to move V4, don't just peel it off the chest and then stick it to the other side. Make sure every time you move an electrode around that you're using a new sticker, so that we get best conduction, that conductive gel's there. We want to make sure we're putting on new electrodes onto our leads every time we move them around. So we're going to take V4 and move it to the right, so that makes V4R. And then on the back, we're going to take V5 and V6 and move them on the back, so that becomes V8, V9. So V8 will be the fifth intercostal space, mid-scapular line. So again, make sure you're following that fifth intercostal space around. That's really where we want to make sure our electrodes are. And V9, you can just landmark it. Again, fifth intercostal space. We're basically going to go in midline between the spine and where you put your V5, which is now V8 and V9. The visualization of how we're going to do our 15 leads. So the first thing we're going to do is we are going to take our lead V4. We're just going to unclip it. we're going to get a fresh electrode. Don't just grab that rando one that's been sitting on the shelf for the last 3 tours. Like, we're going to get a new fresh one to make sure that electroconducting gel is at its optimum. So with that, we're going to landmark again, so that midclavicular line, making sure not to go too close to the sternum. And we're going down to that 5th intercostal space. So again, you'll still have to do skin prep on this side as well, so you might have to shave the chest on the right side as well. So then we're going to take our V5 and V6, we're going to unclip those, and then we're going to go to the posterior of the patient. So again, fresh electrode stickers there, so we're going to make sure we landmark. So we're going to that mid-scapulary line. And again, that 5th intercostal space, that's kind of the same for all of them now. So the 5th intercostal, so mid-scapulary, 5th intercostal, and we put our V5. And we're going to go to our V6. So to landmark V6, the easiest way to do it is go to the midline between the spine and V5 on that 5th intercostal space again. And we're going to place them on the back. Now, the big thing to keep in mind is, like I mentioned before, that we have to do proper skin prep. So if your patient's very diaphoretic, we may have to dry off the back, just like when we did on the anterior side of the chest, now posterior. If the patient has a lot of back hair, we may have to shave their back as well, so we get good electroconduction and good placement of our leads. So an alternative view as well is you can do a fully posterior ECG. So this is when we move V4, V5, V6 to the back and relabel them V7, V8, V9. So this one just looks at the posterior wall of the heart. It doesn't actually look at the right side of the ventricle. The reason you might want to do this is, again, if your 12 lead comes back normal, but you're thinking that there is possibly a posterior STEMI, we can look at this here. So usually posterior MIs accompany 15 to 20% of STEMI. So if you want to do more diagnostic to that area of the heart, that's when we would do this. So with that, what we're going to do is we're going to take V4, V5, V6 and just switch them up to V7, V8, V9. So when we do this, what we're going to do is we are going to take our V4, again, put a new electrode sticker on. We're going to follow the anterior axillary line, so basically the back side of the armpit, and again, following that 5th intercostal space around, we're going to place that on. Then we're going to find that mid-scapulary line again. We're going to take our V5, and again, follow that intercostal space. So 5 and 6 are the same placements as when we did our 15. We're just adding V4 to the back of this one. And then V6 goes midline between V5 and the spine. Again, still following that intercostal space around. If you're really motivated, we could do a full-sided right 12 lead. We don't tend to do these too often in the field because we would do one on the left and then we'd have to take electrodes off and do one on the right. But if you're really suspecting right-sided, you can do these. So basically to do this, we're just going to take all of our electrodes and do a mirror image of what we normally do for our 12 lead, and we're just going to do it all on the right side. So with this one here, the line marking is going to be similar. So we take V1, but this time that's going to go on the left side of the sternum. Again, 4th intercostal space. And then we're going to take V2, and just like we did before, we're going, but now mirrored, we're going to go to the right side of the sternum to that 4th intercostal space. And then, yeah, we're doing V4 again. So again, midclavicular line, line markings all the same. Again, find that 5th intercostal space. Again, might have to move adipose or breast tissue out of the way to get to that space, but we're going to put on V5. And again, all the skin prep rules still totally apply to doing it on this side as well. So you might have to shave both sides of their chest if you want to do a regular 12 lead and then a fully right-sided 12 lead. You're going to have to shave basically the whole chest here. So again, V3 goes right in between V2 and V4. Same thing as we did before. And then we take our V5. Again, if you like to do V6 first, that's totally fine. So we go to that anterior axillary line, to 5th intercostal space, making sure we follow that curvature of the ribs. It's not a straight line. It is in kids, but not adults. So with that, then we're going to take V6. If we're choosing to do V5, then V6. So we find that mid-axillary line in the armpit, and then again, follow that 5th intercostal space around and place it there. And then you just do your 12 lead as you would normally do on your Zoll. So now the big thing is that when we're doing a 12 lead and we're doing 15 lead, if we're doing just leads on the back, if we're doing the full right-sided, the Zoll doesn't know we're doing that. It just treats it all the same. So whenever we do switch up where the lead placements are, we have to make sure we label it on the actual EKG strip itself. So when we do this, if you're doing a 15 lead, we're going to have to label our ECGs. So V4 now becomes V4R because we took it from the left and we moved it to the right. V5 becomes V8 and V6 becomes V9. So if you have trouble remembering this, just remember V4 becomes V4R because we took it and moved it to the right. V9 is an upside down 6, and then you could just use V5 as your V8. I don't have a good one for that one. So if we do a posterior, so we move V4, V5, V6 to the back. So this one, V4, is going to become V7. We're not moving to the right, so it's not V4R anymore. So now it becomes V7. So this is lead 7. V5 is still V8, and V6 still becomes V9. So because we had our first initial 6 on the front, we moved these to the back. So 1, 2, 3, 4, 5, 6 on the front, and 7, 8, 9 is on the back. So when we do a full right-sided 12 lead, we're going to have to label the whole strip. So basically everything is just going to have an R added to it. So we show that we did it on the right. So again, the Zoll doesn't recognize any of this. It just knows that you're doing a 12 lead. So if you're doing a full right-sided, you're going to have to make sure you relabel every single lead. Your 1, 2, 3, AVR, AVL, AVF doesn't change because those are still your limb leads, but you're still going to have to change every single V leads there. So your precordial leads to make sure they're labeled appropriately. In and listening in on this presentation on ECG lead placement in our ACS patients. I just want to make a really big point here. Like I talked about before, skin prep's really important. Landmarking is definitely important for our patients so we're getting the best view of the hearts possible. We also have to have a much higher level of suspicion when it comes to ACS. So if you have anybody with abnormal symptoms such as dizziness, generalized weakness, if they're complaining of like chest discomfort, we should be doing more 12 leads. We want to make sure that we're checking these hearts. If someone has unexplained bradycardia, again, we want to make sure we're doing 12 leads and or 15 leads. So if you ever suspect that you have a right-sided MI, ensure you're doing those 15 leads as well, because the sooner we do our diagnostics, the better it is for our patients, so we can get them to the care that they need. So thank you very much for listening to this presentation, and I hope you found it useful in your practice.